You didn't just go to any clinic, you did your research. You found someone who said they treated tinnitus, so you went in expecting answers. Instead, you got a hearing test, some beeps, maybe tried to be sold a hearing aid, and then given a pamphlet about some apps you can use on your phone. And you walked out thinking, seriously, that's it? Here's the thing, if that's what your tinnitus evaluation looked like, there's a very good chance it wasn't a tinnitus evaluation at all. Most tinnitus evaluations are not, to be honest, and if yours wasn't a real one, you missed the chance to find out what's actually causing your tinnitus. For over 20 years, I've been evaluating tinnitus patients, and I can tell you this, claiming to treat tinnitus and actually knowing how to treat tinnitus are two very different things. Today, I'm going to show you exactly what the difference looks like. I'm Dr. Lane Garrett, founder of Timpanogos Hearing and Tinnitus here in Utah. To be fair, there are audiologists and ENTs who do thorough tinnitus work, but they're the minority, and that's a real problem in our field. The American Academy of Otolaryngology Head and Neck Surgery, the major medical organization for ear, nose, and throat physicians, recommends a comprehensive audiological evaluation for anyone with bothersome tinnitus, not just a pure tone test. Most clinics run a very basic hearing test. Maybe do something called tympanometry and note mild high-frequency hearing loss, or say your hearing's normal and there's nothing I can do, or they jump straight to a hearing aid recommendation without real investigation. That's not tinnitus care. And if you've been through that experience, you probably felt something was missing. You just didn't know what to call it. And honestly, early in my career, I wasn't doing all of this stuff either. I was trained as an audiologist, not a tinnitus specialist, and there's a real difference. It took years of additional study, advanced certifications, and if I'm being straight with you, watching patients not get better to understand that a hearing test and a pamphlet was never going to be enough. It bothers me sometimes when I think about my early career, and that's part of why I'm so focused on doing this right now. Maybe you're thinking, but they said they specialized in tinnitus, they had it on their website, so maybe I just have a hard case. Is that actually what happened, or did you get the standard hearing workup with a tinnitus label on the door? Think about what the appointment actually looked like. Did they spend real time on your case history, asking when the tinnitus started, what triggered it, how it changes with stress or sleep or jaw movement? Did they measure your distress with a validated questionnaire? Did they do pitch matching, loudness matching? Did they even tell you what frequency your tinnitus was at? Or did they run the same test they run on every patient who walks in, regardless of why they came? Was it for hearing aids or a tinnitus? And then they call that a tinnitus evaluation because that's what you asked for. There's a big difference between a clinic that treats tinnitus and a clinic that treats hearing loss and also sees tinnitus patients a little bit. You may have walked into the second one thinking that it was the first. And that's not your fault. The marketing doesn't make the distinction obvious, but the evaluation does, if you know what to look for. If no one has ever explained this to you before, that's exactly why I make these videos. Hit the like button and subscribe so you don't waste another appointment not knowing what to ask for. Most people don't know this. Tinnitus with a completely normal hearing test is not unusual at all. Research published in the Journal of Neuroscience found that people with tinnitus and normal hearing thresholds showed significantly reduced auditory nerve fiber responses, what we call hidden hearing loss. The standard hearing test misses that completely because it only measures whether you can hear soft sounds. It says nothing about the neural health of your cochlea. A 2023 study in Scientific Reports confirmed this in a large sample. People with chronic tinnitus and normal hearing test showed reduced cochlear nerve responses, weaker middle ear muscle reflexes, and increased activity in the central auditory pathways. None of that's going to show up on a regular hearing test. So when someone says, your hearing is fine, I can't do anything about it, they've essentially said the lobby looks okay without checking for a fire in the back of the building. Beyond hidden hearing loss, a routine hearing test can't tell you whether your tinnitus has a somatic component, whether jaw movement or neck position or pressure on certain parts of your head can change the pitch or volume of what you're hearing. Research from the University of Nottingham showed that this is far more common than most clinicians realize, and it points toward a completely different treatment path than hearing loss-driven tinnitus care. A standard hearing test also can't tell whether you have pulsatile tinnitus that's synchronized to your heartbeat, which can signal a vascular issue that needs medical workup, not a random sound machine. And it can't tell you the single most important variable for treatment planning, How distressed are you across all of the dimensions that tinnitus actually affects in your life? A beep test will never answer those questions. So what should a tinnitus evaluation actually include? Here's what we do in our clinic. First, a detailed case history before we even start testing. When did the tinnitus start? What triggered it? Is it constant or intermittent? Does stress, sleep, caffeine, or noise exposure change it? Has it evolved over time? The answers direct the testing. Second, a comprehensive audiological test protocol that goes way beyond the standard hearing test. We'll do extended high-frequency audiometry because that's where that hidden hearing loss often lives, frequencies that a standard hearing test doesn't even look at. We also do otoacoustic emission testing to assess inner ear hair cell function at the cellular level, and careful pattern analysis on the audiogram for notches and configurations that correlate with your tinnitus frequency. Then we do psychoacoustic tinnitus testing, and this is a step that most clinics skip entirely, and it does matter. We do pitch matching, having the patient identify the frequency that most closely resembles their tinnitus. We do loudness matching, measuring how loud the tinnitus actually registers in decibels above their hearing. And what surprises most people is that tinnitus that feels deafening is usually only a few decibels above their hearing threshold. That tells us something that's really important about how your brain is amplifying a small signal into something overwhelming, and it becomes a data point that we track as treatment progresses. We also measure the minimum masking level, the lowest intensity of external sound needed to completely cover your tinnitus up. This tells us how the tinnitus relates to the surrounding acoustic environment and directly informs any sound therapy targeting we might use in our treatment. Now, if that feels like a lot of testing, good. That's the point. Tinnitus is not simple, and a 20-minute appointment was never going to get to the bottom of it. Then we also do somatic screening. Every tinnitus gets asked to clench their jaw and tell me what happens to the tinnitus. We check neck movement, specific pressure points around the head and face. And if those movements change your tinnitus, we know that at least some of this is somatic. That completely changes the treatment approach. We need to address those physical triggers, not just the auditory system. And fourth, pulsatile tinnitus screening. We're going to ask about the character of the sound. Is it rhythmic? Does it sound whooshing? Then I have them count the pulses while I check their wrist. If the numbers match, that person's going to go to an ENT before we do anything. Pulsatile tinnitus needs a vascular workup. Sending someone home with a white noise app for pulsatile tinnitus isn't just unhelpful, it can be genuinely dangerous. And fifth, we do validated distress measurements. We use the Tinnitus Handicap Inventory, a well-validated clinical tool that measures the functional, emotional, and catastrophic impact of tinnitus on daily life. The THI gives us a baseline severity score at intake and tracks whether that score actually improves as we go through tinnitus treatment. The Tinnitus Functional Index is another strong validated option. Either way, some validated instrument needs to be in the room. A 10-second verbal check-in of how bad is the tinnitus on a scale of 1 to 10 is not a clinical measurement. It's a guess. Without a validated questionnaire, you have no objective baseline, no way to demonstrate treatment is actually working, and no way to catch early if something's actually getting worse. We're also going to do a medication and medical history review. Dozens of medications are associated with tinnitus as a side effect. Earwax, ear infections, Meniere's disease, TMJ dysfunction, any of these can drive tinnitus that looks identical to primary tinnitus on a hearing test. If no one screens for those things, they may be treating something that had a much simpler fix. And if no one has ever walked you through any of this before, that's not because your tinnitus is untreatable, it's because the evaluation never happened. And here's another way to tell whether you're working with a genuine tinnitus specialist or someone who added the word to their website. Look at what treatment options they actually have available for you. A real tinnitus specialist doesn't just use one tool. They have a menu, and they match the tool to what the evaluation actually found. Hearing aids are a part of that menu for many patients with hearing loss. Properly fitted hearing aids with sound therapy features address the auditory deprivation that drives a lot of tinnitus. But hearing aids alone are not a tinnitus treatment program. They're one component. Sound therapy is another one of these things, but not just here's an app or use a sound machine. Structured sound therapy means calibrated sound at specific therapeutic targets, often tied to your pitch and loudness matching data, that's delivered consistently as part of a protocol. That's genuinely different than downloading a rain sound app. Another one that we might use is tinnitus retraining therapy, or TRT, that combines directive counseling with low-level sound therapy in a very structured protocol designed to facilitate habituation. It's one of the most established approaches in the field. A real tinnitus specialist knows TRT and can either deliver it or connect you with someone who can. Then there's cognitive behavioral therapy, adapted specifically for tinnitus, that addresses the anxiety and catastrophic thinking that turns tinnitus into the consuming, overwhelming sound. The research on CBT for tinnitus is some of the strongest we have, and the American Academy of Otolaryngology guidelines specifically recommend it for persistent, bothersome tinnitus. If the clinic doesn't offer it or can't connect you to it with someone else, that's a meaningful gap in their care model. And then there are other advanced options like Linear, a bimodal neuromodulation device that pairs sound delivered through headphones with a gentle electrical stimulation to the tongue. That sounds crazy, but the research behind Linear is very compelling. It targets neuroplasticity, working to change how the brain processes tinnitus, not just helps you cope with it. This isn't something you're going to find in most hearing clinics. It requires specific training, specific equipment, and a provider who is invested in staying current with where tinnitus treatment is actually going. When you ask a clinic what treatment options they offer, the answer tells you almost everything. We have hearing aids and some sound therapy options. Is very different from a clinic that can walk you through hearing aids, structured sound therapy, TRT, CBT, and Linear, and explain which one fits your specific evaluational findings and why. One of those answers comes from a tinnitus specialist. The other comes from someone who listed tinnitus on their website. I recently saw a patient named David. He came in after being seen at 2 other clinics, and both of them said they took care of treatment on their websites. Both ran a hearing test, noted some noise exposure history, and suggested a white noise app. He'd been using one of those apps for 14 months. He told me that he'd stopped going to his book club, too much background noise, too many conversations happening all at once, and it made the tinnitus unbearable that left him exhausted. He'd noticed that he'd stopped sleeping through the night, and he said he felt like he was losing his mind a little. Not dramatically, just this slow, grinding feeling that the sound was winning. When we went through the full evaluation, 2 things surfaced immediately. His tinnitus handicap inventory score was in the severe range, and when I asked him to clench his jaw, his tinnitus changed notably. He looked at me like I'd done something unusual. He said no one had ever asked him to do that before. What we found was significant somatic involvement. Both his jaw and neck were both contributing to his tinnitus. And when I went through his medical history, I found out he started a new blood pressure medication about 3 months before the tinnitus began. Nobody at either previous clinic had even asked about that. We coordinated with his prescribing physician on the medication and got him working with a physical therapist on his jaw and neck, and then we also fit him with hearing aids with proper sound therapy programming. We also added cognitive behavioral therapy counseling to work through the anxiety that had quietly overtaken his life over the last 14 months. At a follow-up appointment 6 months later, his tinnitus handicap inventory score had dropped from the severe range to mild. But more than the score, he said, "I'm sleeping. I've gone back to my book club." He had stopped obsessing over every sound in the room. He told me, "I've got my brain back." That's not what happens when you download an app. That's what happens when someone actually takes the time to understand your tinnitus. So how do you know before you book the appointment whether you're going to a real tinnitus evaluation or a hearing test with a label? Ask directly. Do you use validated tinnitus questionnaires like the Tinnitus Handicap Inventory? Do you do pitch matching and loudness matching? Do you screen for somatic involvement, jaw movement, neck movement causing tinnitus? Do you screen for pulsatile tinnitus? Do you review medications? And what treatment options do you actually have available beyond just hearing aids and basic apps? And then look for the provider. Do they hold the certificate holder in tinnitus management from the American Board of Audiology? The CHTM requires advanced training in exactly these areas. It means someone has invested seriously in learning how to evaluate and treat tinnitus, not just to administer a hearing test and reach for a hearing aid. If the clinic can't answer yes to those questions, you're getting a hearing check, which might be useful, but it's not a tinnitus evaluation, and you deserve to know the difference before you walk in. Now I want to know, when you went in for your tinnitus evaluation, what actually happened? Did anyone do pitch matching? Did anyone check if jaw movement changed your tinnitus? Or did you get the standard beeps and be told to get an app? Drop a comment below. Your answer might help someone else watching this realize they actually deserve better. Before you book your next appointment, go through our free Learning Center. It covers exactly what comprehensive tinnitus evaluation should include, step by step, so you know what to expect and what to ask for. It will change how you walk into that room. The link for this can be found in the description below. You don't have to keep guessing. And if you're here in northern Utah and you're ready for an evaluation that actually looks at the full picture, you can schedule with one of our clinics along the Wasatch Front. We'll do the work that should have been done the first time. You can find a link to make an appointment in the description below as well. Thanks for watching. You deserve actual answers.